We are live now. Good evening, everyone. I am Arpita from the IGCP group, and it gives me immense pleasure to welcome you all to today's insightful webinar organized on the occasion of World Parkinson Disease Day. We are honored to bring together two of the most distinguished minds in the field of neurology for this session titled Modulating the Brain Advanced Therapeutic Option in Parkinson Disease. It's a privilege to introduce our esteemed speaker and moderator for the evening, Professor Dr. Ahmed Subi sir. Sir is an associate professor, Department of Neurology and Neurointervention at MES Medical College, Kerala. Sir has been instrumental in advancing neurotherapeutics and is known for his deep clinical insight and academic excellence. We are equally honored to welcome our distinguished speaker for today, Dr. Lieutenant General Dr. C.S. Narayanan Sir. He is the chairman of Manipal Institute of Neurosciences, Delhi, a visionary in the field of neurology and leader who has contributed immensely to neurological healthcare research and education in India. Today's session will explore the cutting edge therapeutic options that are transforming the way we approach Parkinson's disease, a condition that affects millions globally. We thank each one of you for joining us. Your participation reflects a shared commitment towards learning and better patient care. So, without doing further ado, I would now request Dr. Hamid Sibi sir to give a brief about the topic, and then we'll move on to the presentation of Dr. C.S. Narayanan sir. Over to you, sir, Dr. Hamid.
Good evening, everyone. Good evening, sir. Good
Good
evening,
evening.
every listeners. So, when I got this opportunity to moderate this session, I didn't have a second thought because I was also curious to know about Parkinson's disease, which is a disease which we are dealing with day in and day out. But because our center doesn't have any advanced Parkinson's treatment like a deep brain stimulation or TMS, we usually refer our cases to Sri Chitra Institute in Trivandrum. So that's what we do. We select the cases and we send the cases to Trivandrum, Sri Chitra, and they decide and they call back, get back to us. And most of the patients have got good results with Parkinson's on DBS and other advanced therapeutics which we use. So I was always curious and had read through, but even though I am a basic neurologist, I am trained in neurointervention. So in some way, 2 years back, I channeled myself to neurointervention. I did my FNB from Bombay. So I lost a bit of a touch. So I thought this is the perfect opportunity to get back on track, to give a better treatment for Parkinson's patients who are still coming to me and who has motor symptoms and who are responsive to levodopa. Because I have always, when I knew about this, I knew that the treatment, when we refer to such patients who are on our follow-up, should not be too early or too late. So I want to hear from Sir. I know that Sir is a distinguished speaker, a teacher at Manipal. So I'm very eager to listen from Sir about much of that. And I have many doubts in my mind. I hope everything will be clarified. And if at all I have something remaining, I will ask you at the end if I get a chance if I get a chance when others' doubts are clear. So over to you, Sir. Happy to have you here on this platform and eager to listen from you and learn from you, sir. Thank you.
Thank you for the very kind introduction. And I must thank Ankana for choosing this topic that is modulating the brain, advanced therapeutic options in Parkinson's disease. As it happens, I retired from the armed forces about 38 years of service. And while I had the privilege to work in Army Hospital R&R, we were the first team to do the deep brain stimulation in an Indian patient in the year 2000. So I was part of that team. And of course, several persons who specialized in the field have taken it to a much greater height in the subsequent years. But it is a very important topic for all of us to be aware because we do encounter patients frequently in clinical practice who would benefit from this therapy. Next slide, please. Yeah, as we all know, Parkinson's disease is a progressive neurodegenerative disorder characterized by motor symptoms such as bradykinesia, rigidity, resting tremor, and postural instability, and also a bevy of non-motor symptoms. These symptoms result primarily from the degeneration of dopaminergic neurons in the substantia nigra, pars compacta, and the subsequent dysfunction in the basal ganglia thalamocortical circuitry. While dopaminergic therapies like levodopa remain the mainstay of treatment, their long-term use is frequently associated with motor fluctuation and dyskinesia. And as we all know, both the patient and the clinicians who treat these patients get very frustrated with these complications. Deep brain stimulation has revolutionized the treatment landscape of Parkinson's disease, offering symptomatic relief for motor symptoms and improving the quality of life in appropriately selected patients. The last line is very important. It is not a panacea for all patients with Parkinson's disease. A very, I wouldn't say small subset, but a subset of patients only would benefit from this treatment. And it is our duty to select this group before offering this therapy. Next slide, please. The scheme of the presentation will be, firstly, we'll talk about the mechanistic underpinnings of the deep brain stimulation, the clinical efficacy and indications, patient selection and programming strategies, ongoing innovations, and other approved and emerging indications for DBS. Before we proceed further, a couple of lines about the historical background. The conceptual foundation for DBS dates back to the 1960s, wherein stereotactic lesioning procedures were done in the basal ganglia, and this found quite a bit of success. However, the modern iteration of DBS was pioneered in the late 1980s by Benabid et al., who demonstrated that high-frequency stimulation of the thalamic ventral intermediate nucleus, that the VIN nucleus, could suppress tremors in Parkinson's disease patients. This innovation shifted the paradigm from ablative to adjustable reversible neuromodulation. Next slide, please. Next slide. So over the subsequent decades, DBS targeting the subthalamic nucleus, which is abbreviated the STN, and the globus pallidus internus, abbreviated the GPI, gained widespread acceptance. As you saw in the previous slide, the earlier target was different, which was the VIM, but subsequently it was kind of established that the STN and the GPI were better targets. After quite a bit of research and presentations, the FDA approved the STN and GPI DBS for Parkinson's disease in the year 2002. So as it happens, like I told you in my opening statement, we had done this procedure before the FDA approval as such in the year 2000. Since then, advancements in neuroimaging, surgical techniques, and device engineering have refined patient outcomes and broadened the therapeutic scope. Next slide, please. Coming to the mechanism of action, the very fact that there are so many proposed hypotheses means that we do not clearly understand what is happening. As long as the patient is benefiting, it is fine. But of course, we must understand some of the possible mechanisms of action. One is the inhibition of a hypothesis, wherein high-frequency stimulation mimics the effect of a lesion by inhibiting neural activity in the target nucleus. On the other hand, there is also an excitation hypothesis, which says afferent and efferent fibers are excited, leading to functional rebalancing of the basal ganglia circuitry. There's a disruption hypothesis, which says DBS disrupts the pathological oscillatory activity and abnormal synchronization within the motor circuits. And lastly, it also could be that DBS modulates neurotransmitter release, particularly dopamine and GABA, contributing to its therapeutic effect. It is also possible that multiple mechanisms exist, but like I said, we do not clearly understand how this procedure works as of now. And as I've alluded in the previous slide, next slide, target selection is very important. We'll talk about targets for other diseases, but in Parkinson's disease, there are two primary targets, the subthalamic nucleus or the STN nucleus. This is preferred for patients requiring medication reduction. It is associated with significant improvements in motor function but also carries a higher risk of neuropsychiatric side effects. So it is important to know that we're talking about medication reduction. That itself implies that even after this procedure, many patients would require to continue the medications. The other target, that is the globus pallidus internus, the GPI nucleus, is effective in controlling dyskinesias and are less likely to cause cognitive and mood disturbances. So both motor fluctuations and dyskinesias are important complications of late stage Parkinson's. And so we do target two different types of nuclei by DBS. There are also emerging targets such as the pedunculopontine nucleus, the PPN, which are under investigation. And these are especially useful for axial symptoms like gait disturbances and freezing of gait, which are not currently addressed by the current stimulation procedures. Next slide, please. Next slide. Yeah. So the important thing, like I've told, is the selection of patients. Not all patients with advanced Parkinson's are suitable for this procedure. And so we must carefully select these patients. One of the most important criteria is to exclude PD plus syndromes. So they do not benefit from this procedure. So they must be excluded from the use of DBS. Idiopathic Parkinson's disease with motor symptoms responsive to levodopa is the primary indication for DBS in Parkinson's. The presence of motor complications such as dyskinesias and fluctuations, which are refractory to medical therapy, is another important indication. And they should have the absence of significant cognitive impairment or severe psychiatric comorbidities. These are also well known in our population of patients. So we must consult with a psychiatrist and exclude these conditions, because if they do have such conditions, they do quite poorly. Lastly, we must have both the patient, the doctor, and the attendants must have realistic expectations and adequate social support. Because like I said, the medications have to continue, kind of bounce back to the pre-morbid state, and they can have some complications. The device has to be programmed properly. So there are a lot of challenges even after the procedure. This must be kind of addressed before the procedure is offered to the patients. So they must undergo multidisciplinary evaluation, including a neurology consultation, neuropsychology consultation, and a neurosurgery assessment prior to DBS. Next slide, please. Coming to the surgical techniques and imaging, these have, of course, advanced over the years. Now, like I said, we are into the 25th year of DBS in our country. So the electrode placement requires stereotactic neurosurgical techniques, including MRI guidance. Intraoperative microelectrode recording, MER, can improve targeting precision by characterizing the electrophysiological properties of the target nucleus. So this is also routinely offered in centers which are doing this procedure with high frequency. There's some recent innovations which include MRI guided surgery, asleep DBS. We thought that it is always better to keep the patient awake so that we have some kind of a feedback when this lesioning is done. But now we know that the patient can be put to sleep with local anesthesia, and it eliminates patient cooperation. Directional leads are another important advancement. In the earlier iterations of DBS, the leads were multidirectional, so the current would flow in all directions. Thus, the side effects were also more. Directional leads is a very recent advancement which allows current steering to optimize efficacy and minimize the side effects. Next slide, please. As I said, doing the procedure is the easy part. Programming and optimization post-procedure is a very vital component of the overall management of these patients, and it is essential to tailor the therapy for each individual patient. This involves adjusting the amplitude, the pulse width, and the frequency to achieve symptom control while minimizing the side effects. So this is not an easy task. It can be done only in experienced centers by experienced operators. STN-DBS often requires more complex programming due to its proximity to the limbic and associative territories, and that is why, as I said, they are more prone to neuropsychiatric side effects. So the programming is also needs to be very accurate. GPI-DBS typically offers a more broad therapeutic window. Emerging trends include closed loop or adaptive DPS, which use real-time biomarkers such as local field potentials to dynamically modulate stimulation. This is a very recent advance, and like my co-chairperson said, it is already being offered in our country in some centers like Sri Chitra. Remote programming, of course, is a boom. I'm not aware whether it is available in our country so far, but it facilitates access for patients in remote areas. Obviously, patients moving to very specialized centers frequently is a problem. If remote programming is available, it would mitigate this problem a lot. Next slide, please. Next slide. Yeah. Talking about the clinical outcomes and efficacy, numerous randomized controlled trials and longitudinal studies support the efficacy of DBS. We all know that the motor symptoms improve and the UPDRS3 scores improve by 40 to 60%. It is not perfect, but it is very good. Medication reduction is possible, particularly in those who are offered STN-DBS. And as I've said, and it's worth emphasizing that it is not like freedom from medication. The procedure does not mean that the patient can be free of all medications. They by and large have to continue the medication, but it may be possible to reduce the dose and so the side effects of these medications. Quality of life, which is a very important component, has also been shown to improve. They improve in their mobility, daily functioning, and overall well-being. However, it also must be known that deep brain stimulation is less effective for axial symptoms such as speech, balance, and also the non-motor symptoms. So there's a whole lot of symptomatology of Parkinson's disease which are not addressed by DBS, and we must be true, to ourselves while we discuss these problems before the procedure is offered to them. We must not offer it as a complete panacea. Next slide, please. Talking of the adverse effects and complication, DBS is generally safe, but not without risk. And there's a huge amount of experience. And fortunately, in India, there are a lot of centers which offer these procedure, including our own. Firstly, the surgical risks. While doing the procedure, there could be hemorrhage, infection, and hardware complication, because after all, a foreign body is introduced deep into the brain. There could be stimulation-related side effects. Because of excessive stimulation of adjacent structures, there could be dysarthria, paresthesias, and mood changes. And as I said, these are more common with STN than GPI stimulation. And long-term issues, there could be declining benefit over time due to disease progression, cognitive decline. So to address these issues and to mitigate the risk, the patient must be carefully selected. There should be skilled surgical execution, and also programming should be highly individualized. Next slide, please. Some special considerations bear mention. The cognitive and psychiatric effects are more associated with STN-DBS, and these include impulse control disorders and mood fluctuations. So they may require additional medications to manage these patients. DBS in the elderly is a challenge, but age alone is not an absolute contraindication. Functional status and comorbidities are more relevant. We've seen patients who are 80, 85 who are perfectly healthy and without many comorbidities, but they have advanced Parkinson's, so they should not be denied the procedure just because they're old. On the other hand, more and more research is being done to offer this procedure to younger patients. Trials such as early STIM suggest that better quality of life when applied earlier in the disease course. So far, we've been kind of selecting patients on the basis of failure of oral therapy in the form of less effectiveness, motor fluctuations, or dyskinesias. but increasingly some researchers suggested that the quality of patients may be much better if it is offered earlier on in the course of the disease. What about innovation and future directions? A lot of work is being done, and many of these advances are already being offered, including in our own country. One is adaptive DBS, where there's a real-time modulation based on biomarkers like beta oscillations, which are recorded in the target field. Electrocardiography integrates symptoms for improved feedback. Machine learning algorithm to predict optimal settings and improve outcome forecasting. Rechargeable in smaller devices, which enhance patient convenience, and the combination of integration of pharmacological and rehabilitative intervention, which is, of course, very important in all patients who undergo this intervention. A couple of slides about the other indications and targets for DBS. Parkinson's disease is not the only condition where DBS is effective. As we gain experience in Parkinson's, we kind of did research in so many other areas. Essential tremor is one such area where the response is pretty good in those who are not responding too well to drugs. We all know that it is a very disabling condition. So the target in patients with essential tremor is the original Parkinson's disease target, which was the VIM, the ventral intermediate nucleus of the thalamus. In dystonia, GPI is the most effective target, and it is being offered both in generalized and segmental dystonias. Pediatric use, particularly in DYT1 positive patients, has been very effective. In refractory epilepsies, the anterior nucleus of the thalamus is FDA approved. As we extend the indications, we've been using it in cluster headache and the management of chronic pain as well. And in these patients, the hypothalamus or the periventricular and periaqueductal gray, which are important structures for pain management, are the targets. Apart from the neurological indications, there are some psychiatric indications as well. Obsessive compulsive disorders is one such, where the target is the anterior limb of the internal capsule, the nucleus accumbens, and the subthalamic nucleus. However, it is still a research area, and there are some FDA exemptions which need to be obtained before it is used for OCD. In major depressive disorder, the experimental targets include the subgenual cingulate gyrus and the medial forebrain bundle. In the Tourette syndrome, the targets are the centromedian parafascicular nucleus and the GPI. In conclusion, deep brain stimulation remains a cornerstone in the management of advanced Parkinson's disease, offering significant motor and quality of life improvements. Please advance the slide. Next slide. Next slide. Next slide. A deep understanding of its mechanisms, the precise patient selection, and the integration of technological advancements are crucial to maximizing the benefits. As DBS technology continues to evolve, it holds a promise of more personalized, adaptive, and effective neuromodulatory therapies. And its role in treating a broader spectrum of neurological and psychiatric disorders underscores its importance in modern neuroscience. Thank you very much.
Thank you, sir. Thank you very much, sir. This was a very crisp and very useful presentation, sir. Thank you for this simplification of this information to all of us. You have, I initially, before the start of the talk, I had told you that I had some more doubts within my mind, but I am more or like cleared of most of my doubts which I had in my mind. And but few things I still remaining in my back of my mind is, sir, actually regarding the procedure I had doubts, like not the surgical. How is it a pure surgical thing? And when you tell a patient regarding this DBS, when you convince a patient or counsel a patient regarding DBS to go to a center or to send this patient, how will you say it? Like, is it a purely surgical thing, like a neurosurgical
No, no.
procedure, or
Actually, all aspects must be mentioned very clearly to the patient. Firstly, we must not offer it as a panacea to all patients. So we must carefully select the group. Like I said, those who have complications due to the therapy, like motor fluctuation, dyskinesias. Of course, like I said in some subsequent slides, it can be offered early in some patients, but that is not the standard of practice now. Secondly, we must also not tell them that once the procedure is done, they'll be off all medications. So they will have to continue the medication. Some of them may undertake this procedure thinking that they are overburdened with a combination of so many medications. We must tell them that many of those medication may continue even after their DBS is done. Thirdly, we must not downplay the side effects. So we must talk about the immediate complication, the surgical risk. We must talk about the psychiatric side effects which can happen because adjacent structures are very close by. The limbic system is very close by to the subthalamic nucleus. So we must talk about these as well. And lastly, we must also tell them it is not like a open and shut thing that the day after the surgery they walk out and all is good. They must have a full commitment to come repeatedly for programming and modulation of the device. And so this requires a lot of support from the caregivers also. They must have the wherewithal to come to the center repeatedly. So all these must be assessed before we offer the procedure to them. So, in the subset of patients where all of this is fitting in, of course, it is a very good procedure. But we must address all these issues. The surgical procedure itself is, I mean, considering that so many complex surgeries are being done by neurosurgeons, the placement of an electrode deep into the brain under a constant feedback and with so many monitoring mechanisms is not so challenging these days.
Nice, nice. And how many days of hospital stay would you expect, sir? Like, if it goes without exception.
I think the patients can be discharged the very next day.
Oh, I see. Okay, nice,
Yeah,
nice to
yeah.
hear.
So absolutely, and they would be obviously called for programming. You know, once the electrode is placed, then of course some programming is done in the OT itself. So that and like I said, there are two options: either the patient is completely awake, so that he like in the very first patient that we did, for example, there's a dramatic decrease in the bradykinesia. So a neurologist is always in the OT when the procedure is done. So, to assess whether the tremor decreases, whether bradykinesia, some of these motor symptoms like respond dramatically even within the OT itself. And so the programming parameters are adjusted in the OT, and subsequently they have to be repeatedly monitored and adjusted during follow-up visits.
So, what do you think, sir? In future, will this non-surgical neuromodulation like TMS or direct current stimulation, transcranial current stimulation, or focus ultrasound, would it be able to compete with DBS to give a good outcome?
I think, like particularly focused ultrasound has got a lot of promise. But these are ablative things. This is akin to the earlier, kind of neurosurgical procedures which is done to ablate the basal ganglia nuclei. But the advantage of deep brain stimulation is a neuromodulatory technique wherein we are able to have some control over the response subsequently. So neuromodulation, I think, will always have a good role. And like I said, there are so many advances happening, like unidirectional electrodes which are happening, and there is closed circuit modulation. So every year the hardware is improving. So this technique will always have a place in the management of Parkinson's. But of course, like in every field of neurology and medical science, other advancements will go pari passu with it.
Yes. Sir, I'm not sure whether any comments or doubts have come in the chat. I am unable to see that.
Yes,
Arpita, can you? Yeah, please.
yes, there are two questions. Let me put them forward. The first question is, what are the most promising emerging therapies in neuromodulation that we might expect to see in the clinical practice over the next 5 to 10 years?
We are talking about neuromodulation in general, or we are talking about neuromodulation for Parkinson's disease.
So it's not specified anything.
I
So,
think it's about Parkinson's.
yeah. So for Parkinson's disease, the best available therapy is deep brain stimulation. But like my colleague said, focused ultrasound and so many other therapies are also emerging. But if you're talking about neuromodulation in general, for example, or migraine, there are lots and lots of therapies which are being offered over and above the medical therapies which are available. Some of them are remote electrical, neuromodulation, wherein the arm is selected, but the stimulus goes up to the brainstem, and there is downward currents which relieve the patient from the migraine headache. So lots of non-invasive neuromodulatory therapies are available. For example, vagus nerve stimulation for epilepsy. But for Parkinson's disease, this remains the mainstay, and the most experience has been obtained for this procedure as of now.
Right, so one more query is there. Can you share insights into how personalized medicine and precision neurology are shaping the future of therapeutic strategies in Parkinson's disease?
So, as in every field of medicine, personalization is very important. But this personalization is very, very important in certain diseases. Even more important in some patients who've got genetic problems. For example, I'm just saying, like in certain types of epilepsy, where we use Tegretol. It has got a lot of side effects in a subset of patients who've got some gene disorders. So it is very important to choose this kind of a therapy after doing the genetic test. So that is this is what is called personalized medicine, when we have to choose the correct patient for the correct treatment. In deep brain stimulation, like I said, the personalization comes in selecting the patient. It's very important. Personalization comes in addressing the modulation and adjusting the parameters, the programming parameters subsequent to the procedure. So a lot of personalization is to be done depending on the type of patient, the type of effect that we are wanting in the patient, the type of side effects they have. So all this, and like I slipped in one of my slides, so fortunately we have access to machine learning algorithms now. So we can make use of these algorithms to refine our approach and personalize our approach to the management of each patient and tailor the approach for each patient.
So how much would be the rough cost? I know it depends on the cities and experience, everything I know. But if at all we tell a patient to in a metro, how much would be roughly around the
I think around 5 lakhs.
Oh, only 5 lakhs. Okay. And this rechargeable and non-rechargeable batteries, I have heard of it. I didn't go deep,
Yeah,
but
so like the best example, the electric EVs that we're having, battery technology is changing so fast, at a very, very rapid pace. So as of now, it's like a cardiac pacemaker. The battery will run down, but fortunately, it's not a few days or a few months, in a few years. And the battery pack and all that is kept in the chest, very much like a pacemaker. So we don't have to fiddle around with the electrode which is deep in the brain. So that is the least of the problems. But I'm sure, I mean, they will develop batteries which have, will live as long as the patient lives in the near future. The one
thank you.
important, I mean, just an aside is that these batteries, if at all the patient succumbs to the illness, these batteries, including the cardiac pacemakers, have to be removed before the cremation. That's a very important aspect. They can be disastrous if the patient is cremated along with the battery.
How comes that? If patient is cremated, what happens then?
Yeah, the
Uh,
battery, there could be an explosion.
oh, I see. Okay. Okay.
So,
And
so
these are not
we
MRI
must
compatible.
remove the battery before the patient is, cremated.
And these are not MRI compatible. So if a patient with the DBS develops stroke and we need to take a MRI immediately, how's it like? I just came
No,
into
no,
my
no,
mind.
no. All the, including cardiac pacemakers, it is the same thing for here. The
Okay.
recent iterations of these batteries are all MRI compatible.
Oh, I see. Okay. And sir, regarding the genetics, you just brushed it regarding epilepsy. So same thing happens in Parkinson's disease, like LRK, K1, LRK mutations and all. So this
Yeah,
genetic Parkinson.
I don't think there's been kind of a lot of advance because they're not like single gene disorders, right? Very rarely. They're like a combination of genes, and they are kind of risk genes rather than causative genes. So, as of now, talking about personalized medicine and tailoring the treatment on the basis of these genes which have been identified in these patients, is, I don't think is a realistic prospect. But of course, like all genetic disorders, in subsequently, as we understand more about the genetics of any disorder, gene therapy is round the corner. As we all know, in certain disorders like SMA, it is already a reality. And of course, it will be much more effective in single gene disorders, but in multi gene disorders and multifactorial diseases like Parkinson's, it may happen, but it's not near term.
My question was, sir, in YOPD, young onset Parkinson disease, likely due to a genetics disease, genetic cause, would DBS? I couldn't come across studies saying that DBS would be helpful, or we treat it just like a normal Parkinson's disease.
No,
Any
you treat
advantage?
like a as of now, the concept is you treat like a normal Parkinson's till, because the younger the onset, the more the chances of the developing complications earlier due to the therapy. Motor fluctuation, dyskinesias, and all that will happen younger in a younger age in them. So they can be offered. In fact, possibly since comorbidities and all may be less, because when they develop these complications, DBS may be even more effective in them.
Sure, sir. Sure. So thank you for summarizing this entire DBS treatment in half an hour time. So what I got was that this is not a complete panacea for Parkinson's. It's not complementary. It's supplementary. Even if you do a DBS, we have to have some medications for some time, and we have to go for a regular follow up. And patient selection, just like precision medicine, is the key for this patient. Any patient, we have to carefully select the patient to get a good outcome. Hopefully, that's what it sums up.
Perfectly summarized.
Sure, sir. Thank you.
Right, sir.
Thank you so much.
Sir, so with both of your permission, I would like to conclude today's session. But before that, on behalf of the entire team, I would like to extend our sincere gratitude to both Dr. C.S. Narayan sir for his exceptional presentation, and special thanks to Professor Dr. Ahmed Subir sir for so expertly moderating the session. So thanks to both of you. Thank you once again for your time, expertise, and contribution towards advancing awareness and understanding in this very critical area. So thanks to both of you for your time and effort. Thank you
Thank you so much,
everyone.
Uncle. Thank you, sir. Thank you so much. Bye bye.
Thank,
Thank you very much, sir. Thank you. Have a
Bye.
nice day.
Thank
thank you,
you.
sir. See you.